Good afternoon, everyone. You're all very welcome to our AWARE webinar today on bipolar disorder, journey to diagnosis. So we're just going to wait a moment or two to allow people to join. So taking a moment to settle in and we'll get going shortly. So welcome again to those just joining now. My name is Dr. Susan Brannick. I'm clinical psychologist and clinical director here in AWARE. So for those of you who are new to our webinars, these take place on the second Wednesday of every month. So each one looks at a different topic relating to mental health and features clinical and lived experience. So if this is the first webinar that you're joining with us today, please do have a look at our website, aware.ie, maybe to sign up to receive an email each month about upcoming webinars, and also to find out a bit more about the information, education, and support services that we offer to people living with depression, bipolar, and related mood conditions. So just to say, in our webinar today, we really welcome any questions that you might have. Please do ask questions as we go via the Q&A box. So we may not be able to answer all of the questions, but we'll certainly try to answer as many as we can. And I guess as ever, if anything emerges over the course of our discussion today, really sort of inviting you to tune into that, your own kind of wisdom around self-care, knowing what's going to be supportive for you in terms of listening today, or maybe what you might need to do after, and certainly kind of inviting you to contact a GP or mental health professional if you are left with any other questions or concerns after our discussion this afternoon. So without further ado now, I'm delighted to welcome the panel this afternoon. So Dr. Noel Kennedy, consultant psychiatrist in St. Patrick's University Mental Health Services and clinical director with Highfield Healthcare. Welcome, Noel. And Liam Gildea, our lived experience expert. Liam has shared his experiences of living with bipolar over the last 10 years or so. So very much welcome to you both. Thanks for joining this afternoon. What I might just do is actually ask you to briefly introduce yourselves before we get into our conversation. Maybe Liam, if I start with you.
How you getting on, guys? So thanks for having me on, Susan, and looking forward to this next hour with Noel. So my first name is Liam. I have a bipolar type 2 diagnosis. So thankfully I've been well the last 6 years. So life is good. So this is like it's a hobby now for me, and there's always lots of learnings from other people who have the disorder and experts like Noel and different other psychiatrists.
That's great. Thanks, Liam, and thanks for joining us this afternoon. And Noel, if I might ask you to introduce yourself briefly.
Thanks very much. My name is Noel Kennedy. I'm the clinical director in Highfield Healthcare. I previously worked in St. Patrick's University Hospital for a number of years. And I guess my area of interest, both in terms of research and clinical practice over the last 20-something years, has been in epidemiology, outcome and treatment of mood disorder, particularly bipolar affective disorder. So thanks for the invitation.
Thanks for joining, Noel. Yeah, thank you both for joining this afternoon. Looking forward to the conversation, I suppose, in support of World Bipolar Day this month, and maybe thinking about that idea of journey to diagnosis. So maybe first starting with you, Noel, if that's all right. I suppose for anyone who may not be so familiar with what bipolar disorder is, maybe a bit of a brief overview of the signs and symptoms, or a reminder maybe for those of us who might know a bit more.
Perfect. I guess bipolar disorder really became differentiated from depression probably around the early 1970s, and it was recognized as people having periods of both depression and elation as part of their illness. I guess when we talk about bipolar disorder, it's somewhat different to depression, purely depression, in that it tends to be diagnosed a little earlier than depression, often from really the mid-teens to about the mid-30s. It's more genetic than depression, and it's a little less frequent. About 1% of the population will suffer from bipolar disorder over the course of their life. And as Liam said, about 2% of the population will suffer from bipolar 2. we typically distinguish bipolar. We divide it into, I guess, bipolar 1 and bipolar 2. Bipolar 1 is the classical bipolar people hear about, where people can have periods of extreme elation or irritability, often with reduced need to sleep, increased energy levels, often impulsive behavior leading to overspending or negative consequences, interspersed with periods of depression where people feel low, they have poor energy, they often have poor motivation, they often have sleep and appetite disturbance and impaired concentration. And bipolar 1 is characterized often by multiple episodes of both depression and mania or elation during the course of someone's life. Bipolar 2, which is much more common but much less researched, is where people have more lengthy, intractable periods of depression. It's a little bit more like unipolar depression, often with a later aged onset, and highs or periods of hypomania or mania are usually much shorter in duration, and depression is much more, of course, a part of the illness. So I suppose one other issue is we often try and distinguish between what's called hypomania and mania in an episode. Hypomania is like an exaggeration, perhaps, of one's own normal personality, with increased enthusiasm, less need to sleep, more plans and more ideas, whereas mania is where there's a functional impairment. The increased thinking, the impulsivity tends to lead to negative consequences over the course of someone's life.
Mm. It's an interesting distinction. So that it sounds like, as you're saying, no, that kind of the experience of mania, that it leads to functional kind of difficulties.
Yeah.
So it's going to, so maybe hypomania, not. And I guess there's always going to be a continuum of that, isn't there? But mania kind of can lead to quite extreme circumstances potentially at times, maybe, or yeah. Okay. So there's a lot of terms in there, isn't there? There's a lot of different types, and it may be that many people aren't so familiar even with the idea that there could be different types of bipolar or different variations maybe in that. And I suppose one of our, I guess the focus today is thinking about kind of that difficulty maybe around, or the journey of diagnosis. And I wonder, maybe kind of thinking with you, Liam, maybe a bit about your sort of journey in that respect, and maybe whether some of what Noel sort of said there resonates, and what that's kind of been like for you.
Yeah, look, my recovery, it's probably stereotypical of the average person with bipolar. So late teens, 16, 17, I started feeling a low mood. It was difficult to distinguish at the time because I was a teenager, and to be honest, most teenagers are a bit moody. So that's what I was putting it down to. Now, I was withdrawn from friends. My academic stuff went downhill. Just lack of energy. Even though I was sleeping 9 or 10 hours, still had no energy. But I always try to rationalize it. So I felt like, look, this is something that's just going on with me. And then by the time I get to college, it'll pass. College, much the same. I was having these low periods, just really social isolation, didn't feel comfortable with people, felt very anxious. So this persisted for a number of years. So I started working then. I was in accountancy, so I trained as an accountant around the ages of 22. And my depressive episodes were getting worse. And while I had the stigma inside myself, but I did know there was something wrong. So I got to my mid-20s, and my body shut down really. And I had never heard of depression or bipolar disorder, really. So I remember in 2009, I had a cousin that was quite close to. I just explained to him, and I remember I was in tears just explaining what was going on. So he encouraged me to go to the doctor. So I went to the doctor. I presented myself as severely depressed. They were the only symptoms I told my GP of at the time. So I was treated accordingly. So I was treated with antidepressants. So after a couple of months, my depressive episodes lifted. So unknown to me at the time, what was happening was I was, say, really low for 6 or 7 months, and then all of a sudden, like magic, the depression seemed to lift. And I was going into these periods that I'd finally recognize in years to come that were hypomania. So a bit like Noel said, I just had a huge energy for life. I could just function on 3 or 4 hours of sleep. I was the life and soul of the party. I had this characteristic called rapid speech. So let's say we're having a conversation here now and it's to and fro with rapid speech. It's just one-way train. So, it's just funny things like just running up 500-600 euro phone bills. It's like an inability to stop talking. And a lot of people, looking back to, did you not notice that? And I always say it's like asking me to speak Spanish and recognize it. I didn't have the knowledge in my brain. I didn't have the knowledge in my brain what was going on. I was just so relieved that the depressive episode had lifted. So I got into this cycle then of 7 or 8 months depressed, 4 or 5 months hypomania. So it came to about 2011, and I had a regular GP at that stage. And I remember I went into him for a physical ailment. He tweeted that I was actually manic. Now, he didn't say it to me at the time because he was trying to see could I build awareness of what was going on. I was unable to make that awareness. And by the time I continued the cyclical cycle for about 10 years, 7 or 8 months depressed, 3 or 4 months. As time went on, the depressive episodes were 9, 10 months, and hypomanic episodes were 2 months. The hypomania, I found it very enjoyable at the beginning. But as time passed, I can be very irritable. I can, unfortunately, side effect of the hypomania is grandiose. So you just feel like you're an expert in everything. You feel like you're better than other people, and you're just a bit off kilter. So eventually in 2013, I got the diagnosis for bipolar disorder. So I was referred to a psychiatric centre. I'm from Ballyholme, so psychiatric centre in Claremorris. So they diagnosed me with bipolar type 2. So what's the difference? So with depression, you treat a person with antidepressants. If you treat a person with bipolar disorder with antidepressants, it'll bring up the mood. The risk is it'll shoot your mood up, so you'll have a medicated high. If the mood stabilizes, it stable you out. So I got myself well, and then, like I'd say, it was about 70% of other people with bipolar disorder, I decided to come off my medication. I was 30 at the time. I didn't feel like being on medication for the rest of my life. It just didn't sit comfortably well with me. So I came off my medication. 6 months later, I was back in a severely depressive episode. 2015, I got myself well. Then I didn't learn my lesson in 2016. This time, instead of coming off my medication, partly come off it. So it's not to be advised, I was splitting tablets, and 6 months later, psychiatrist said to me, whatever about the billions and billions of brain cells in our head, they don't seem to like when we come off medication unsupervised. That was my journey. Thankfully, I've been going on the last 6 years, but it took 20 years to get there. It probably took 10 to 12 years to actually get the bipolar diagnosis. Yeah, so I'm fortunate that I'm well.
Thanks, Liam. There's loads of rich sort of stuff in there, isn't there? I guess, as you say, it's there's loads of kind of themes around the medication being one, isn't there? And as you say, kind of that kind of in coming off at those couple of times. But and I suppose maybe the thing that strikes me is this idea that it is a journey, as you said, kind of having those difficulties in the beginning, and actually quite a long period to getting a diagnosis of bipolar 2.
Like bipolar is very individual.
Yeah.
I often talk to people and they're taking the exact same medication as me, and they're like, oh, well, you're well, how come I'm not well? And it depends, because with the evidence we have, it looks like it's 70% chemical imbalance and 30% environment. But that's just an average. So for somebody else, it could be, maybe for me, it was 90% chemical imbalance, 10% environment. But if I'm talking to someone and it's 70-80% environment, but the medication will only, like I always say, it's like a dual prong to manage bipolar disorder. It definitely seems to be medication and some kind of talk, but it's so individual for every different person,
Yeah, Yeah. So everyone's experiences, excuse me, are going to be unique potentially under that umbrella. And I wonder, Noel, about that idea as well. Is that I imagine that resonates with your experience too, that kind of longer route or sort of time from kind of recognizing that things aren't okay to a formal diagnosis, maybe?
Yeah, I think Liam has described his story and his history really fluently. From my point of view, as a psychiatrist, what he's describing is sadly not unusual. Most people will have a depressive episode, and it's often undiagnosed before they will develop a clear-cut hypomanic or manic episode. And sometimes people will have two or three or several episodes before they even come in contact with a GP. And kind of people kind of stoically dust themselves down and try and get on with life. Just a couple of points about that. With bipolar disorder in particular, it's a highly recurrent illness. And what I mean by that is if you have one episode, you've about a 90% chance over the rest of your life of having another episode. So getting correct diagnosis and treatment is really, really important. I suppose the second reason is depression hugely affects us all functionally. If you're feeling like you're tired, you're apathetic, you're lethargic, you can't function with your partner, you can't really function at work. It's a pretty horrible place to be long term. And that obviously affects your social functioning, but also if people are manic, and it can also lead to functional impairment, but it may, as Liam outlined, having recurrent manic episodes probably isn't good for your brain either long term. There's definitely data on this. So I think making a diagnosis as early as possible is critical. I would say on average, most people will not attend someone like me for about 10 years after they've had an episode of depression or mania. So there is still a long duration of untreated illness, and that often can predict a worse outcome over time. It's difficult to diagnose. There are many other things that are going on in people's 20s and teens. Social anxiety can often be seen before someone has a full-blown depressive episode or a manic episode. People, we're all adjusting to big life changes in our teens and 20s. We're probably still finding ourselves to some degree. I think most of us only have kind of a gentler sort of feel about our personalities when we get to our 30s, but often in the teens and 20s, life is very up and down, and you're making major changes in your life, leaving school, going to college, maybe taking a job, meeting new people, relationships. So often substances can people often, because we experiment more when we're in our 20s, people can use alcohol more or take other drugs, and that can often mask symptoms of depression or mania, or indeed can exacerbate symptoms. So there's quite a lot to tease out when one sees people. I think the first key is to get some information and get a good GP to take a history. But generally speaking, if someone has bipolar disorder or high suspicion of it, generally I think referral to psychiatry would normally be really helpful, because we tend to work as part of a team. Most of us will have team psychologists and occupational therapists and other team nurses so we'll all work as a part of a team, and that really helps treatment and outcome over time. But I think making a diagnosis can take time, even when we're treating people with mood disorders day in, day out. It can still take us 6 or 12 months to be absolutely sure this is bipolar, not something else. So I think it's slow, careful assessment and treatment really makes a difference over time.
Yeah, absolutely. And I guess there's work to do in mental health kind of circles of recognizing bipolar, isn't there, and kind of understanding that. And as you say, the importance of a full history, and whether a GP may be able to begin that process, or maybe that is more of a referral for the diagnostic part to a mental health team. And maybe, Liam, really, I guess just kind of connecting in what you said. And I suppose I was thinking for anyone listening here who might not have a diagnosis necessarily, but a lot of what you're saying might really resonate with them. Do you know? So I wonder kind of what you see is maybe helpful, or what you found helpful in that journey that you've described, or what someone listening to might could take away from that.
Yeah, like I think first of all, it's just being brave and finding a good support network.
Yeah.
So any psychiatrist, once we got the medications right, next question was, what's the support network? You need, it's as if you're on a football team, you need supportive people around you, whether it's friends or close family, and it can make a key difference, because I was lucky now, my friends never judged me for having a health condition, and even when I was depressed, they'd bring me to events I mightn't like to go, but maybe just that maybe feel a bit 2% better, like. So yeah, it is a tricky one, but I think, like, I would always say, like, the cornerstones of being well with bipolar disorder is medication and sleep. For me, they're the cake in my experience, and then the rest is the item. If, like, some people would nearly look at bipolar disorder as a sleeping disorder, because if you think about it, when I was depressed, I just wanted to stay in bed all the time. But I'd always wake, if I could get to sleep, I always wake up around 4 or 5 in the morning. And it's like the witching hour. And, I always tell people, if they're waking up at that time, mentally something right. And on the other side, you can work off 2 or 3 hours sleep. And I remember a psychiatrist said to me before, he said, if you want a relapse in bipolar, other things I find helpful is a discipline routine. There's this new therapies now. I think it's interpersonal and social therapy. Actually looking at the importance of a routine for bipolar disorder. I think a routine is good for everyone. And look, I wasn't employed a lot of the time when I was having these episodes. When I was trying to recover, I think when you're unemployed, it's harder to keep a routine. But it's just to stick to a routine, and the normal things. Just being aware of, there's this thing called the circadian rhythm in your brain. It's just like a clock. But the more regular your sleep is, so for me, I tend to go to bed around 11, and I wake up naturally at 8. I'll know if I'm up till 3 or 4. Okay, occasionally I can do it. I'm regularly up at 3 or 4 and sending WhatsApps, my mates, who are almost spotters of the condition. They'll send a message to my wife saying something off. I personally, I don't know anyone that's doing well with bipolar that isn't on medication. I think that's something you have to embrace. I would say that the day I started running towards the illness instead of running away from it was key. And I think when you get comfortable with the condition, the stigma goes away, because what other people think, they think. It's a very hard. I always say from the other point of view, I always say, if I never had bipolar disorder and somebody I knew had it, would I understand what they're going through? I wouldn't. So, if there's a stigma attached to the condition, I'm okay with that. But it did take 14, 15 years to get to the stage where I was, it can be quite comical at times, where I've often been sat in a psychiatric center and I know someone from home, and they're a good bit older than me, and they're like, oh, I have that thing you have. And I always smile to them, and I always say, you can say the name. It doesn't devalue you to say the name. But yeah, there'll always be a bit of a stigma.
Yeah, I guess it can be difficult, as you say, the kind of the stigma maybe, and the lack of understanding around what it means to have bipolar, or and even the difficulty of naming that maybe, and people being in quite different places with that over the course of the time. And as you said, it's a really nice way you've described it, actually, of running towards the condition. I guess you sort of linked that in a way, if I'm understanding you right, to, I guess, as you said, most people that you kind of know are managing bipolar with medication, that being quite a central bit. But I guess that comes up a fair bit, doesn't it? That can be, I suppose, a bit of a complex relationship then.
Yeah, well, look at and unfortunately, I sat in front of counselors who told me that I don't need medication, that I can dampen your emotions, and it's well, from an ethical and professional point of view, they shouldn't be saying it. But there is, there is I would say anti-medication is a bit strong, but a lot of people, and I was in this category, I hated medication. And I always felt like if I do the right things, if I eat well, if I try and sleep well, if I exercise, if I do all the right things, what I always say to people is if you can't pinpoint, you could have a situation of depression, maybe you have a family bereavement, or someone has a long-term health condition. What I always say with people is if you can't identify a reason for feeling so bad, and I was at the point where I'd struggle to get into the shower. I always think because I often thought like, I had a good job, I had great friends, I had a partner, yet I was still depressed. So I think there is, and even someone said to me recently they said, oh, you must be coming off your medication now that you're well. And that's what got me into trouble in the first place, where I was like, I don't need that medication. And, you know, I'm no expert in it, but mild to moderate depression, medication may not be the answer. But for something like severe depression, bipolar disorder, schizophrenia, I just think it's like taking medication. And I always say to people, it's like being a diabetic. You don't second question the fact that you take them. In my opinion, my chemicals aren't just right in my brain. And look, the proof's in the pudding. I've been taking medication for the last 5 years. And, a lot of people say to me, oh, you still must have your bad days. I don't. I don't have any bad days. I don't have ups. I don't have downs. I'm fortunate. But, the evidence is, first, for me anyway, the medication seems to work a treat.
Mm-hmm. And I wonder, Noel, about whether that kind of resonates with your experience. I guess some of that kind of, as you say, Liam, we don't have the same conversations about insulin for diabetes or something like that. There's lots more meaning potentially attached to medication in mental health more generally. And I wonder, Noel, in your experience around that, as Liam's been saying about medication.
Well, I think Liam has very fluently described a lot of the evidence-based interventions in bipolar. So there's a huge expertise there learned over many years of experience. I wouldn't be evangelical about treatment, but I do think a little bit of everything helps. And that's true for most of our psychiatric disorders or conditions. I think the way we tend to look at things is, as Liam has put it, some people may have mild depression and there may be a psychological treatment or even occupational therapy that will largely work. Or people may have a very severe bipolar disorder with very disabling symptoms. And in that case, there may be a need for more medication longer term. I'm always of the belief that I work together as part of a team with other professionals such as psychologists, occupational therapists, CBT therapists, and that we all work together, we communicate with each other, and that's where people get the right outcome. So I think it's really important to look at things in a very broad-based, multidisciplinary way, but not to neglect any aspect of treatment that can really, really help. And I suppose just going back to what Liam talked about, lifestyle, a lot of that sounds like common sense, but it really, really makes a difference. And there's actually really good evidence-based data looking at adherence or compliance, plus mild lifestyle changes actually can reduce risk of a further episode for many years in many cases. Just to pick up on what Liam said, sleep-wake cycles we recognize as one of the major contributors to a further episode, particularly of mania. So getting a good night's sleep, most no, you know, we all have times where we want to be out and do fun things in our lives, but generally getting a fairly set amount of sleep is really, really helpful in terms of reducing risk of another episode. I think that area Liam talked about, which is acceptance of a diagnosis. And as you said, you know, if you have diabetes, insulin can prevent complications and can prevent illness. It is quite similar, I think, in particularly in bipolar 1 disorder, where people may need to be on a little bit of medication long term. Simple lifestyle adjustment, as in, I always talk about reducing stress levels, and that's never possible. And no one in my job wants to impair anyone's lifestyle in any way. But if you're very hardworking and your job is stressful, looking at areas of your life that you know can help, a long walk after a good day's work, or you know some kind of balance and relaxation is really important. You know, being careful with alcohol is an issue, and again, we don't want to impair anyone's lifestyle. And socialization is really, really important when people have episodes, but definitely not to drink alcohol to excess, because it is a central nervous system depressant. I generally say avoiding substances is a good idea. If you have a tendency to bipolar, often with cannabis particularly, there's a very strong literature suggesting a much worse condition and sometimes very long-term psychotic type symptoms. So that's clearly something to reduce or avoid. Again, cocaine can have significant psychoactive effects and can affect outcome. And Liam also mentioned the idea of a spotter or someone you love, and we may get on to talk a bit more about this later. Having someone in your life who can spot episodes or even incipient episodes is really, really important, because when people are depressed, they'll hands up full straight away. They'll be on the phone to me and they'll be saying, you know, you got to do something. I'm not feeling very well. But when someone's hypomanic, as Liam described, it can be an intoxicating way to be. You know, you can feel, you know, full of energy, lots of plans, lots of ideas, that kind of enhanced feeling of yourself. The problem is none of us can stay hypomanic all the time, and there's inevitably at some point going to be a drop. So it is probably important to tune things down at that stage, because it can lead to kind of cycling of mood and to mood dropping quite badly, as Liam described earlier. The last thing I think is in terms of depression, and again, Liam outlined this, probably the most important thing if someone feels depressed. And we spend a lot of time, you know, even when people are at an inpatient level and very severely depressed, we spend a lot of time working with people on routine. We have therapeutic programs, and it's largely to get people active and have a certain amount of activity in a day. And I'm always talking about turning a 0% day into a 30 or 40% day. So even when you're depressed, a routine, acknowledging you can't be as you are when you're really well, but keeping some little bit of a routine going, even at a lower level, and being kind to yourself, but keeping a routine going, that's really, really important in terms of coming out of a depression. So it isn't all about medication.
Yeah. I guess I suppose what you're both speaking to in a sense is understanding yourself well, isn't it? As I guess, Nola, you're saying, ideally there's a team to support that in mental health services, but I guess it's fundamentally about knowing yourself, and as you say, kind of, Liam, understanding the condition, and I suppose that idea that, even as you're saying, no, different drugs might have different impacts on people. So it's knowing how you might respond if you smoke cannabis versus how your friends do, or that might actually have quite an impact on you. So it's sort of trying to make sense of some of those issues. I don't know if that kind of connects. Maybe it's a kind of a real sort of, it is courageous, I think, to step in and say, well, you know, these are the kind of things that are difficult for me. These are a bit more straightforward, but it's trying to understand who you are. Maybe, I don't know, Liam, do you think that kind of makes sense in a way?
It's just something that Noel brought up, and it's quite interesting. I was lucky. I never really had much interest in drinking, and I never had any addictions. So I think it really complicates the bipolar side of things if you have a dual diagnosis. So let's say you're bipolar and you're also a recovering cocaine addict. It's so hard to treat because you don't know where the mental illness starts and where the addiction begins. And it just makes things so tricky. I mean, so many people, and I'd say the academic, I think it could be up on 50%, I think, people that have, and it's understandable because if you are feeling really depressed, alcohol, it almost just gives your brain a break from that horrible feeling. Then there's also peer support, and I'm wondering, Noel, when you were saying there that
Mm.
you have a team now and you have a psychologist, a cognitive behavioral therapist. Have you seen it? Is it? I know it's happening in the UK, but is it happening in Ireland now that there's somebody like a peer support expert there for someone?
I think it is to some degree, Liam, but we've probably a long way to go, and we won't get political today. But I do think we need to contribute more of our health budget towards psychiatry, particularly psychiatry at the significant end. And so it's patchy in different areas, but I think the ideal is having, say, some, and it depends on where one is as well. If you're doing very well, as you are, obviously, you probably need little other than review and maybe either medical or nursing review every so often, and knowing that if things worsen, that there is a very good backup for you. But with bipolar, people can sometimes not make a full recovery from depression, and I think our biggest problem is where people kind of have long-term lower grade depressive symptoms, what we call residual symptoms, and that requires an enormous effort both on the individual's part, but also OT, cognitive behavioral therapy, all that really improves outcome at that level. I think you also said peer support. I didn't mention that, but that really normalizes bipolar as well. So if you, for example, what we're doing today with Aware or other support groups, having kind of other people around you who understand what you've been through, who can understand the ups and downs, that's massively important for people, and it really destigmatizes bipolar disorder. So I think that was a really important point you made.
Yeah, I think it's a nice balance to have the academic expert and have the lived experience expert, or whatever you want to refer to them, because sometimes I say it's a bit like the driver theory and the driving test. And you need your driver theory to get on the road. Sometimes the driver theory will prepare you for a certain amount, but you don't actually know how you're going to perform when you're actually out driving. So I always think like the lived experience is, and there is something very comforting in when you're speaking to someone. When I was in the psychiatric daycare center, you do draw comfort out of the fact that you're not the only person. And I always felt I was the only bipolar in the village. And I probably was. But when I started meeting more people with bipolar, it dawned on me that okay, this isn't that unusual to have a mental health condition, and there is. So I think there's great opportunities for the peer support. I've never worked with peer support, but I have done courses on it, and I think it's an interesting thing that the Irish health system could embrace.
Just to say, bipolar in terms of psychoeducation and support, it's the most evidence-based of all of the illnesses we treat in terms of outcome. And there's some beautiful studies done in Spain, in Barcelona. There's an expert there, Edward Vieta, and they do a 6-month, when someone's had an illness such as a manic episode or a major depressive episode, they do twice weekly groups for up to 6 months afterwards, which is exactly what we've both been talking about. And that level of support in a group basis with, someone like me, probably with an allied health professional as well, that massively reduces the risk of a further episode over time. In Highfield, we have a day hospital environment, but it's shorter. You know, it might be 6-7 weeks. But if someone's been very unwell and they've needed inpatient admission, stepping down to 6-7 weeks of more psychotherapeutic and occupational therapy basis and group work and group relaxation over a further 7-8 weeks really can get someone confident. They go home, they're meeting people who have similar problems and who are struggling in a similar way. And it gets people out to a level then of more independent functioning over time. So I don't know about how you feel about it, but it's this sort of 9-12 months of care and treatment when someone's had a major episode of mania or severe depression. You know, often people will need an inpatient admission, but it's step down care till someone's really robustly well. That to me is what we really need, and we've a bit to do there, I think.
It takes time to recover, because I remember when I was in my early stages of recovery, I wanted to rush back to work and I wanted to get back. And, you know, I had a psychiatric nurse saying, no, you're not well enough to go back.
Yeah.
You know, you need it. And I ended up, when I got myself to a level of wellness, I ended up 2 years doing small courses here and there. And it was a new for me, you know, all I knew for 20 years was just being up and down. Then I was in this new position in life where my mood was stable. And you almost have to find yourself. You know, it ended up in me completely changing my career, because, you know, a lot of the decisions I made were made when maybe I was high and didn't know the consequences of it. So yeah, you need to take some time out. And well, the pressure is there, you know, you're kind of like, I want to get back to whatever normal is. I want to get back to my normal. But that's where the support services are important. And that, you know, and the cognitive behavioral therapy is quite good. I think, and it has a good success record. With cognitive behavioral therapy, for me, it's more or less just realizing that all these thousands of thoughts that's going on in your head isn't you. And the person that observes the thoughts are you. And I always say, like, all your thoughts, if you personify the person and put them sitting down and get all this negative stuff coming at you, no reason for it, you wouldn't listen to it. So, you know, I think, you know, and learning to challenge your thoughts, and even, you know, even to this day, I still get thoughts of, I don't want to be on this medication. But, you know, it's just coming to the maturity of the fact. But like, I do think I like the cognitive behavioral therapy. You know, and a lot of that too, it focuses in on routine. And Noel mentioned it. Like, when I was recovering, I had a set routine. You know, I went for a short walk. I drove over to the psychiatric center. I walked down to the shop, picked the paper up. I walked back up. If I was well enough, I read a piece of paper. I spoke to a few people. So it kept me busy from, we'll say, 9 to 5. You know, sometimes worst thing can be is sitting at home, dwelling on your thoughts. We are social animals. Even when we don't feel like socializing, I think that we get out there. But yeah, it's definitely a two-pronged approach. It's not. I am pro medication, but I do also understand that it's important than that.
So, and certainly different things will work for different people, won't they? As you say, the importance of the diversity of approaches. And I guess some of this there's some questions coming in, which would be nice to spend a bit of time kind of maybe seeing if we can address some of them. Some of them we've already spoken a little bit about, kind of, I suppose, managing wellness, and kind of the importance of routine and sleep in that. And maybe one question here is what's the best way maybe to approach a person who needs assessment, or to go for an assessment for maybe a diagnosis? Don't know who wants to take that one, maybe.
Well, I can take it, but no one can answer it.
Yeah.
I think a gentle approach, and it's flared with difficulty, because if the person is hypomanic and you approach them and say, I think you're well, you'll generally get thrown away. But if they're in a depressed state or maybe the latter states of their hypomania,
Mm.
just gentle encouragement. You know, like at the end of the day, you can only encourage someone to get treatment. Like when I look back, it was me that had to make, okay, I got the gentle encouragement, but I still had to follow up. I still had to get the treatment. And, you know, it's just a level of understanding and saying, you know, there's nothing. Sometimes people try and understand the disorder, or it's kind of an Irish thing where people tell you, they're like, well, you're not the only one with problems. And then they list out all the people that live around you with their problems. And I understand that way of thinking, but just be careful on it. Like if I'm in a very depressed state and family member or a friend, and it has happened to me where, and they say, well, look at John's down the road and he's after getting a diagnosis with cancer and he's getting on with it. All that does is make the person with depression or wherever they're at, it makes them feel worse.
Yeah.
Then because you're thinking it's so negative, all that used to go on with my head is, oh, I'm a disaster, I'm a waste of space. Look at John up the road. Look how positive he is with his illness. And then look at me. I can understand why people kind of want to tell you, you know, that you're not the only one with issues. You know, and I always noticed it with my GP is that he was always quite positive with me, even in the darkest of days. He always tried to crack some jokes and, you know, maybe got half a smile out of me. But he, you know, so it is a gentle approach, but it's also understanding that once you approach a person and suggest that they may need help or may need to speak to a doctor, after that, I don't think there's much more a person can do. Be interesting to think more.
Yeah, that's really helpful though, Liam. Thank you. And I guess, as you say, kind of knowing where your responsibility begins and ends is really key, and really being gentle in that. Sorry, no, I didn't mean to cut you off there. Go ahead.
I would totally agree with Liam. I think for many people, particularly with depression, they kind of suffer it, and people are very stoical. So I think actually sitting down with someone, a family member or a friend, and saying, well, you know, tell me what's going on, and maybe then involving a GP and moving things along that way, it will always help. And I'm always struck by how many people who end up seeing me who haven't talked about any of their difficulties or the depression to anyone. With hypomania or mania, it's a little more difficult. And, you know, just to say, even, you know, in my job, I will often spend weeks or months with people who may be a little high or very high and clearly aren't functioning well. And it can take time for them to build a rapport with me and so that they even trust me. And that's a lot of it. And then we talk about the illness in a very gentle way, and we talk about what theoretically might help, but it can often take a number of sessions before someone will agree to take some treatment, and then it may take longer, and Liam alluded to this earlier, before people are ready to have discussion about longer term treatment if necessary. Most people will come off medication over a year or two, and my job isn't to say you must do this. I think the days of paternalism are well gone in Ireland. It's to stay with them and to figure out a plan and to work on their behalf over time. And most people will have a balance and say, well, on balance, I think I'm better on a little bit of treatment than not, and availing supports than going away on my own. So I think it can often take quite a time. And I'm speaking as a psychiatrist, but I think it's also true for family members, and having someone on your side to gently nudge you in the right direction can really help.
Yeah, no, that's really helpful. Thank you both. And I guess maybe related to that, there's a lot of questions coming in from people about how they might personally be able to ask for an assessment. So whether that's someone who's already in a mental health team or maybe someone who's not in contact with mental health services.
I think still the first avenue is through GP. The GP will then refer if they, you know, many illnesses can be dealt with very, very effectively and competently by GPs, and GPs often will have a link to psychologists or CBT therapists as well. But if someone has clearly got bipolar disorder, then probably the GP will refer on to services, and there would be usually an outpatient assessment, or if someone is quite severe, it may, day hospital or something like that could be a consideration. But I would say first avenue is always through the GP to do, and they'll have a lot of expertise, and they will have significant expertise in making a diagnosis and even starting someone on treatment, and then they will refer on if they feel they need to.
Okay. And there's a question there that comes up, and we may not have enough time to get into it, but even maybe thinking about resources to maybe signposting, not often spoke about, but it is emerging, I think, this idea of kind of menopause and the relationship of menopause triggering kind of bipolar, whether someone's had a diagnosis later on related to the menopause, or how that might interact with mood changes.
I would say it's not uncommon at all, and about 10% of all the diagnoses of bipolar disorder are made beyond the mid-40s, and we certainly see a peak around the menopause, both of psychosis and of bipolar disorder. The treatment is similar, but again, it's often not recognized, and people may have a period of depression or elation post-menopause. And HRT, to say something positive, in terms of postmenopausal depression, can make a really significant difference on its own. But clearly, if they're more significant depression or elation, again, the pathway of care would be similar. But I suppose, to emphasize, it's increasingly being recognized, and it's not at all uncommon.
Okay, that's great. Thank you. Thank you both. And I guess maybe we might have covered it. So maybe if there's anything more to add in, just a question there on maybe for Liam and Noel, kind of both of you, kind of how people I guess might support a loved one who has bipolar more generally. We've sort of touched on it, but maybe if there's any more maybe to add, because I know a lot of people will be listening kind of with someone in mind as they watch this webinar.
There's small, there are small things you could do, and I think I mentioned earlier is, you can start off with the conversation, and this is the way I would start off and say, I don't fully understand what you're going through. There's anything I can do to help. So you could pick up their medication. You could bring them to their psychiatry appointments. And something that I think is very beneficial is to actually go in with the person for their appointments, because I know when I was very severely depressed, I was very monosyllabic, and I found it very, very actually difficult to concentrate on what the psychiatrist was saying to me. You could offer to go in with the appointment, they could take notes. And so there are small little things. And I know there is an element of fear, and, look, I always had suicide ideation with my condition. Wouldn't have been something I disclosed to my family, but I would have disclosed it to the experts. And I know there is that element of fear. Just think about the small little things that you might be able to do, and make them a nice meal, just basically look after them.
Thank you, Liam.
I would advocate that as well, and I think to be someone's advocate as well is important, because with depression, people can often not look for care. They can get to such a level that you can get so disabled and so lacking in energy and enthusiasm for life that you're actually not able to kind of advocate on your behalf and push towards getting a GP assessment or seeing a doctor or a therapist. And we would always encourage to have one loved one, be it someone's wife or partner or friend, to kind of act as a spotter. And that's particularly true, I think we alluded to this, where the mood is going up a little bit. Often people feel full of the joys of life, and someone who knows someone very well will know, well, things are actually not as good as you think. And the other thing is, people like me love to get a collateral history, so that when two people come, actually having a person's partner who knows them for years, and I might know someone for 3 months, actually knowing that they're not quite as good as and people can often minimize symptoms when they come to see me, and people come in, I'm okay, and then a partner will come in and say, actually, he or she is not. That's really helpful, because otherwise we don't see the full picture. We're not in the person's home, and so really having one person involved in your care, if it's at all possible, it really helps outcome, but it also helps the treating team hugely.
And I guess, Liam, or maybe just a kind of reflection more generally, and that might be that's one of the key themes, I suppose, has come up, is sort of collaboration in a sense as well. So that will be a conversation, I suppose, with someone in your life about what that could look like, and where the boundaries and the safety is around that, as well as what's supportive.
Yeah, and family members will often say that find it more challenging to deal with the person when they're hypo or manic than they are when they're depressed. Like, if they're not a risk to themselves and they're getting treatment for the depressive episode, they're not out and about. But if you're in a hypo phase, and it's happened to me, you're spending money you don't have here, thousands. And I spoke to someone recently there, and they blew 30,000 of the couple's savings. But it leads to so many marital breakdowns, and it is fraught with difficulties. Like, in an overall sense, if I was to give a couple of points on in what recovery is, I think it's not try and outsmart psychiatrists and outsmart a GP. If they prescribe medication, take it. If you don't want to take it, please don't come off it unsupervised, because you're looking at a 90% relapse. You do want to come off the medication, or you are having side effects that you don't want, just go back to the psychiatrist. Might be another medication, and just be reasonable, and just keep an eye. Like I would say that even if you were to talk about the medication number 1, sleep number 2, exercise number 3, and number 4, being social, diet, and just being aware of your thoughts. I probably didn't answer your question there, but
No,
near the end of time, so I just wanted to...
We are, yeah, and no, thank you, Liam. And you actually did to a large degree, and I think that's really helpful what you're saying about what recovery kind of might involve, and as you said, the importance of communication and the kind of pillars. So, and I don't know if there's anything kind of coming to the end, if the kind of even maybe the most important thing, maybe you've sort of said them already, but if you wanted to say anything else about what you would want someone to take away with them from this webinar, very briefly.
It's just embrace the condition. Like, if you asked me in 2017, what did I think about bipolar disorder, I hated it with a passion. I felt like that it had robbed me of a life. And now if you ask me, I don't even know would I change my diagnosis, because it's opened up many opportunities to me. It's allowed me to grow in confidence, to do stuff like this. It's been a springboard to a new career. I've met some fascinating people. I've met some fascinating psychiatrists, nurses, CBT therapists, and I've met some fascinating people with the condition. So, just look at it logically, like any other health condition. And there is a high success. Not everyone. So unfortunately, some people don't get to terms with their disorder. And what I'd always say is the earlier you get your diagnosis, better. And I've been lucky to have some nice experiences where some dad might send me a message on Facebook that his 19-year-old son is bipolar, but doesn't know what to do. And, just being able to have a chat to that guy, and his doctor said to me, it will pass. And sometimes people, and Noel will be able to speak about this, I know the mute medication I was taking, it took about 7-8 weeks to even, and I remember that lad I was talking to, he was just starting off on medication. I was like, hold tight for 6 or 7 weeks. And I spoke to him there recently, and he's doing great. So yeah, just be brave. And I think there is more, there may be a small bit of stigma in it, but there's more mental awareness, there's more awareness of it. And hopefully events like this will.
Yeah. That's brilliant. Thank you, Liam. And thank you for sharing so openly. It's been really helpful and a really good discussion. And Noel, I guess if I was to go to you very briefly, the kind of most important thing that you would want someone listening maybe to take away before we come to an end today.
Perfect. Well, I think, as Liam said, demystifying things and perhaps facing up to if things are not going so well and seeking appropriate care and attention. And I think it's really important that someone like me, we're here to help. It's an equal relationship. We're here to try and find a way forward with someone over time. And my role is to give people choices. So as Liam said, if there's a treatment or a medication that's causing problems or side effects, we'll always look at alternatives and we'll always try and find a better outcome. And there are other ways of working as well as medication treatment. So I suppose to have a broad, equal relationship, and I think to seek out some support and care if you're in distress, that's probably the biggest message, really.
Great. Oh, that's really great. Thank you both so much. I think it's been a really, really interesting conversation with lots of really important areas that we've kind of talked through. And certainly if anyone's interested in learning more, do have a look at our website. We've got World Bipolar Day coming up on the 30th of March. So there's lots of information around that as well. And our programs, so Living Well with Bipolar. So that's a education program, as kind of both Liam and Noel have mentioned, is a really key part of Living Well with Bipolar, kind of having that information and knowing yourself. So that program is going to be opening for registration on the 19th of March, as well as the relatives and friends group. So for anyone who's supporting a loved one who has that diagnosis. So really encouraging you to have a look on our website, but kind of, yeah, just to say thank you again, both of you, so much for your insights and your experience, and being so generous in sharing not just your time, but your experience too. It's been really, really beneficial. So thank you both. And moving then to the webinar for next month. So we will be talking about anxiety and worry. So please do join us if you can. And that's the 10th of April. So thank you all very much for joining, and hopefully see many of you next month. And thank you, Liam and Noel.